We're waiting for a few more people to go ahead and get logged on for today's webinar. As we're getting ready to get started this morning, I also want to extend a special thank you to Kebby Maccabee, who is our Health Promotion Patient Resources Coordinator, and Michael Sola and our entire FightCRC team and staff for helping us get moving and ready for today's webinar. So thank you for all of the team members, and we'll be hearing in a little bit from Kebby, who's going to be facilitating our question and answer session, and we will go ahead and get started this morning. So next slide, please. Okay, so today's speaker, we have Dr. Al Benson, who will be presenting in terms of providing perspective about the GI research as well as in medical advancements, and specifically some of the items and discussion points noted from GI ASCO that was held just about a month and a half ago in San Francisco. After the webinar, we want to remind you that we will be chatting with all of you via survey in terms of getting feedback from you about what worked well, prospective topics, as well as additional information that you'd like to provide to us about our patient education series. I do also want to remind you that this is going to be a webinar that is recorded, so for timely playback at any point to revisit any of the themes or modules. But we want to remind all of you to go ahead and submit your questions real time during our presentation today to get information about the science, the research, and ask timely questions about the specific topics. Just a quick reminder, of course, that this is meant to serve as a general background and information about where we are with the state of the science, but of course this is not a forum for information or advice about direct medical care. Just a quick reminder that Fight Colorectal Cancer does the most to give timely information about what's happening in the sphere of colorectal cancer research initiatives, patient and medical care, but this does not replace your direct medical provider in course of therapy. So just a quick reminder to submit those questions, because we will be having a Q&A session facilitated by Ms. Maccabee, and we'd love to have any of those thoughts and ideas that are rumbling around really answered, and have Dr. Benson have a bit of time for discussion. One reminder is that the Fight Colorectal Cancer team is very much dedicated to funding science, and this year we've actually we're actually dedicated more monies towards our LISA fund, which is specifically dedicated to late-stage colorectal cancer research, and 100% of those funds directly go to the research grants, specifically for investigators who are really looking at innovative and really novel therapies around late-stage disease. So you on the side will notice the amount contributed throughout the years and the investigators. So really excited to have an investigator out of Italy who's receiving about a $100,000 donation from us in terms of the LISA fund donation. And just a reminder that of course we accept those philanthropic donations on behalf of our funding science initiative, being the LISA fund. Next slide. So get involved. We just want to remind you all that at our FightCRC, joining our Facebook initiatives, Twitter accounts, that it's really easy to like us. It's really easy to join Twitter. This is one of our advocates, David, who's very excited, who was with our photo shoot with us and became very engaged in FightCRC as a colon cancer survivor and has been an awesome advocate. We just want to remind you that there's a place for everyone within our initiatives at Fight Colorectal Cancer. And so we'd really love to have you think and learn a little more about what we're doing. We have grassroots advocacy campaigns all the way to direct research advocates and support for training in these areas, or even sharing your story and becoming connected within our community is a great way to very much become connected to FightCRC and the survivors and advocates within your community. Next slide. So as I was mentioning before, we do want to remind everyone that Fight Colorectal Cancer provides good and timely information, but it's of course no replication for direct medical care. In an emergent situation, 911 should be called, and of course your medical provider and team should be directly involved as a partner in your health care, as we provide just general information and insight, very much in favor of making sure to have a very robust medical team to help you in your direct journey through the medical treatment and care. Next slide. And today I just want to welcome Dr. Al Benson, who is from Northwestern University. He's a member of the ASCO committee and currently member of the Task Force on Quality of Cancer Care and co-chair of ASCO's Colorectal Cancer Guidelines Committee, especially specifically for the stage 2 panel and for use of radiofrequency ablation for colorectal cancer hepatic metastases. So Dr. Benson's research is primarily in the area of gastrointestinal cancer and clinical trials, cancer clinical trials, and biologic therapies, which makes him really astute in terms of presenting today about the topics that we'll be covering, advancements for colorectal cancer, and being someone who's very much respected within the GI community and a world-class clinician and researcher in being in initiatives himself. I'm Andy Dwyer from Fight Colorectal Cancer and a joint appointment with the Colorado School of Public Health and University of Colorado Cancer Center, and very excited again to join all of you with Dr. Benson today. Next slide. Okay, so with that, I'd like to hand over the reins to Dr. Al Benson in terms of presenting. I will actually be covering a lot of the Dr. Benson will be covering a good number of the specific GI topics today. We're also going to spend a little bit of time talking about research advocacy for fight colorectal cancer and how to become directly involved as a research advocate in securing and helping keep the research agenda with legislators as funders throughout the country and world around thinking about advancements for colorectal cancer. And again, a good portion of the time is going to be dedicated today to really thinking about the direct questions that you might have based on the topics that are presented. So with that, I'm going to go ahead and hand it over to Dr. Al Benson. Dr. Benson?
Thank you so much, and I would like to thank Fight Colorectal Cancer for this wonderful opportunity to be with you today, and also to thank them for all they do for our patients, but not only for our patients, but also for those of us in the research community where Fight Colorectal Cancer has been phenomenally supportive and very interactive as we design new clinical trials and obtain feedback from Fight Colorectal Cancer as well as other patient advocacy groups. So I'm very indebted to them for all the work that they do and their many, many interactions. The GI Cancer Symposium is a very large worldwide symposium, and lots of data were presented, and unfortunately we don't have time to cover all of the important issues, but Fight Colorectal Cancer and I sat down and we tried to pick a few topics that we hope will be of interest and certainly reflect state-of-the-art in terms of some of the very important research initiatives. So why don't we go to the first topic, and this is a presentation that was addressing vitamin D and colorectal cancer. Now, as many of you know, vitamin D is a very important vitamin that helps the body use calcium and phosphorus to make our bones strong as well as our teeth. We get our vitamin D primarily through exposure of the skin to sunlight, but it also can be obtained from some foods and dietary supplements. There have been many studies in humans, most of them relatively small, but nonetheless suggesting that higher intakes of vitamin D or higher levels of vitamin D in the blood are associated with a reduced risk of colorectal cancer. There have been many studies in colorectal cancer looking at prevention, and these include various dietary maneuvers as an example, but the field is also looking at dietary effects for people who have had a colorectal cancer or currently have metastatic colorectal cancer. One of the great advantages of many of the clinical trials we do is that it opens the door to conducting many other investigations with the data that we've obtained from patients on clinical trials. So this is a very good example of that. In 2014, a very important National Cancer Institute sponsored trial known as CLGB 80405 was presented for the first time, and this was a very large phase 3 trial for patients who were receiving their very first treatment for newly diagnosed metastatic colorectal cancer. And basically this trial was looking at chemotherapy. Patients could have either FOLFOX or FOLFIRI chemotherapy with either cetuximab or bevacizumab. And the design was to see if there was an overall survival benefit favoring one regimen over the other. It turns out that there was no definitive difference between these regimens. And so what this trial supports is current guidelines where we have a number of different regimens that we can offer our patients when they are first diagnosed. Now from this study, patients did have blood drawn and their vitamin D levels were tested. Also, patients filled out detailed questionnaires and asking them what supplements they were taking, including vitamin D. And this is not an unusual type of what we call health services research, where we're trying to make various associations. And so in the past there have been similar studies with colorectal cancer patients looking at issues like diabetes and obesity as some important examples, as well as exercise and the association of survivorship with the diagnosis of colorectal cancer. Excuse me. Now, in most labs, the normal vitamin D level is between 30 and 74 nanograms per milliliter, as reported on our lab sheets. Now, what we do know is that vitamin D levels are often very low. I live in the Midwest, and the majority of people in the Midwest have low vitamin D levels. I guess we don't quite get enough sunlight. But in this particular study, you can see that the median vitamin D level was low at 17.2 nanograms per milliliter. And what we also have learned, and from this study, it reinforced this, that the lower vitamin D levels were associated with older individuals, African Americans, lower dietary and supplemental vitamin D intake, those who were on the obese side, and those who had lower physical activity, as well as if the blood was drawn in the winter and spring, which I guess makes some sense because certainly in the Midwest we haven't had much sunlight during those months of the year. And what this study suggested, that patients with the highest vitamin D levels actually lived longer compared to those with the lowest levels. And you can see the difference, 32.6 months versus 24.5 months. What this study shows, by the way, is although we want to constantly improve median survivorship, this study gave us the best results we have seen to date in terms of overall survivorship. So it really does support the regimens we are using, particularly people who are exposed to multiple regimens over time. And it also suggests that vitamin D may be very important. Let's go to the next slide. So vitamin D levels we think are important, but we really don't know is whether taking a supplement will in fact help patients live longer. Patients who participated on this trial were actually quite healthy. They had an excellent performance status, but it also showed that if you have higher vitamin D levels, overall people appeared to be healthier in general than those with low vitamin D levels, and this will require further work. What does this mean for our patients? If you want to know your vitamin D level, you should certainly discuss this with your physician. It is possible to increase vitamin D levels naturally through sunlight and dietary sources. We do have to be careful with sunlight, however. We don't want people getting sunburn and increasing the risk of skin cancer, but sunlight is an important source. But there are important foods such as fatty fish, fish liver oil, and eggs that can enhance vitamin D levels, and many foods are fortified with vitamin D, milk being one of the very common foods that we routinely use, as well as juices and breakfast cereals. But we don't recommend that everyone start taking a lot of vitamin D pills. You can have too much vitamin D that can be harmful. It can increase calcium levels, which can lead to deposits of calcium salts in tissues such as kidneys, heart, or lungs. And it can even lead to what can be very serious increases in blood levels of calcium. So there is a website here listed for you that talks about vitamin D, and we would urge you to speak with your doctor about vitamin D. In addition, there's further work in terms of clinical trial work to enhance our understanding of vitamin D and colorectal cancer. I'd like to go on to the next presentation. We're going to switch gears a bit, and we're going to talk about rectal cancer. And this was a presentation that was looking at the role of surgery for people who received what we refer to as neoadjuvant therapy, which is initial therapy before any initial surgical consideration. So for patients with rectal cancer, particularly those with stage 2 and stage 3 rectal cancer by clinical assessment, pre-surgical chemoradiation is a standard of care followed by surgery, and in many cases after surgery followed by additional chemotherapy. There has been interest in whether or not there may be subsets of individuals who may not actually need surgery. And there have been some cancer centers who are beginning to look at this concept of avoiding surgery in their patients. And generally, this is for people who have received chemoradiation, and it appears that all of the tumor cells have been killed when biopsies are taken, or for those who have surgery where we see no evidence of remaining cancer. And so for those individuals where it appears all the cancer cells are killed, perhaps surgery is not necessary, and people can be monitored very carefully to make sure that there's no evidence that the tumor recurs. And of course, if it does, then surgery would be important. we know that, of course, with surgery there can be important side effects, and if we can avoid surgery, at least for some of our patients, that would be a good thing. So this was a small study from Memorial Sloan Kettering in New York, and there were two groups of patients. There were patients who had chemoradiation followed by surgery, and after surgery the pathologist did not see any evidence of tumor cells in the tissue that was removed at the time of the surgery. Then there was another group of patients who did not have surgery because it looked like the chemoradiation killed all the cancer cells on evaluation. In both cases, patients were very closely monitored, and if tumors appeared to come back, for those who had not had surgery, then they would go on to appropriate rectal surgery. Next slide. So you can see there were just over 70 patients in each arm, the arm that had surgery versus the arm where there was no surgery, so it's a relatively small study. There was regrowth of tumor at the original site in the rectum in 19 of the patients out of the 73 who did not have surgery. There was, unfortunately, there were some people who went on to develop metastatic disease in both groups, and this is why after treatment we monitor patients very carefully to make sure that tumor doesn't come back. But in both cases, the majority of patients were alive after 4 years. And in the group that had surgery, maintaining the rectal muscle, which is important for bowel movement control, was achieved in almost 3/4 of the patients. And of course, with patients who didn't have surgery, that wasn't an issue. Next slide. So what does this all mean? Certainly, as a research venture, there is more work that's ongoing to get a better understanding as to which patients may avoid surgery. It does suggest that watchful waiting after chemotherapy and radiation for rectal cancer may be an option, but only for very carefully chosen patients, and that would be those individuals who had no visible evidence of tumor cells after their initial treatment. And as I suggested, we need more clinical trials to enhance our understanding of who might benefit from actually not having surgery. Next. So we're now going to look at a trial that is looking at another drug that targets angiogenesis. In colorectal cancer, we currently have available 3 drugs, bevacizumab, zivaflibercept, and regorafenib, all of which are currently available for patients with metastatic colorectal cancer. This study was looking at a drug which has been approved for use in stomach cancer, for example, but there was interest in looking at this agent known as ramucirumab for patients with colon cancer. So this study was known as the RAISE study. It was a randomized, double-blind study of the FOLFIRI regimen with irinotecan, folinic acid, and 5-fluorouracil, plus either ramucirumab or placebo for patients with metastatic colorectal cancer who had already received initial therapy with bevacizumab, oxaliplatin, and either 5-FU or capecitabine, but had shown evidence of progression and therefore needed an alternative regimen. So this whole process of angiogenesis is the formation of new blood vessels, and we know that tumors need blood vessels to grow and spread. And what are known as angiogenesis inhibitors, and the agents I mentioned are known as angiogenesis inhibitors, also referred to as anti-VEGF agents, which is the target of these inhibitors. They're designed to prevent the formation of new blood vessels, thereby stopping or slowing the growth or spread of tumors. This slide mentions there are two drugs currently approved for colorectal cancer that target VEGF, the bevacizumab and ziviflubercept, but the agent regorafenib also has anti-angiogenesis properties. And this study was designed to see if ramucirumab actually added benefit to the chemotherapy regimen FOLFIRI. I mentioned it's approved in gastric cancer. It's also approved in lung cancer currently. Let's go to the next slide. And these are the results. You can see it was a very large study of over 530 patients in each arm. And this study did show the benefits of adding ramucirumab. You can see what the median survivorship is for a second-line regimen, and I can tell you that these numbers are quite good for a second-line therapy. There were, of course, side effects. There was a little bit more risk of lowering white blood cells when you add ramucirumab. This class of drugs can produce high blood pressure, and that was more pronounced compared to the placebo group. And other side effects like diarrhea and fatigue were fairly comparable. Next slide. So what we can say about these results is that ramucirumab increased overall survival a little bit. The side effects are similar to other drugs of this type, including bevacizumab and ziviflubercept. If this is approved by the FDA, it will offer yet another treatment option. Although having said that, it will be interesting to see how people would choose among these drugs, whether someone would get bevacizumab, ziviflubercept, or ramucirumab. And part of the problem here is there's a fair amount that we don't know about anti-angiogenesis drugs. For example, we can't predict which patients will respond to any of these drugs. There are no genetic tests or other blood or tumor markers that will tell us that a given individual would be best treated with one of these different approaches. And what we also don't know, if a person has received bevacizumab as their first therapy, will ramucirumab help them in a second-line regimen? We do know, for example, with bevacizumab and ziviflubercept, that prior exposure to bevacizumab does not mean that people will not further benefit from this anti-angiogenesis approach. So now many people receive anti-angiogenesis therapy such as bevacizumab either first or second line. So we'll see if this goes before the FDA, what happens in terms of colorectal cancer. Next slide. So now I'm afraid we're going to address something that's pretty complicated, and I'll try my best to clarify this phenomenon. Many of you know that immunology is felt to be critically important in terms of the development of cancer, that we believe that there is something that goes awry in the immune system that allows tumors to flourish. And for many, many years, there has been tremendous interest in immunotherapeutic approaches to cancer treatment. Unfortunately, we've had many disappointing results. However, this body of work has continued to support the potential of immunotherapy. And we have now reached a new era that is very, very exciting, where we think we're making real progress in immunology. Not only have a number of drugs been developed, I'm going to show you some, but we're learning much more about the human immune system and how to tackle it. So one area of interest is immunotherapies that target what's known as the programmed death ligand, referred to as PDL, and that particular pathway. Now, this particular pathway, which is relative to the anti-tumor immune response, is an example of a class of drugs which we call inhibitory pathways. And so what you might hear is that people refer to these as inhibitory drugs or as checkpoint pathways. These checkpoint molecules actually mediate tumor-induced immune suppression. And normally what we've learned is that this programmed death pathway is involved in preventing tissue damage, for example, when people have chronic inflammation. And now we've learned that many human tumors express this PD ligand, referred to as PDL1, and that often when people have tumors that have this PD ligand on their tumor cell surface, it's associated with a worse prognosis. There's also the importance of lymphocytes. Lymphocytes are important types of white cells that are important with the immune system. And lymphocytes can also congregate around tumors, and they're called tumor infiltrating lymphocytes. And we found that tumor infiltrating lymphocytes from patients with cancer typically will express PD1, and therefore this can impair how well the lymphocytes are actually working to assist in fighting the cancer. So I know this is complicated, but in fact this diagram you see is a very simplified diagram, but you can see the PD1 attachments here to lymphocytes, for example. And the ability, if we can kind of suppress these type of attachments, to have a big effect on improving what has been immune suppression and presumably allowing tumors to grow. Next slide. And this is just another graphic, again showing this very complex interaction among important immune cells, including lymphocytes and the tumor cells, and the role of PD and PD1 and PDL1. And what actually this helps to show is that activated T cells that could kill tumors are specifically disabled by those tumors that express this PDL1 and bind to PD1 to interfere with the ability to actually attack the tumor. So at the bottom you'll see what, in general, what we want to do is ask the question, can we generate tumor-killing T cells? Can these T cells actually get to the tumor? Can the T cells kill the tumors? And can actually the T cells be turned off? So this whole process dealing with PD-L1 and PD-1 is attempts to address this very complex issue. Next slide. So at the GI Symposium, here is an example of a very small preliminary clinical trial looking at an anti-PD-L1 agent. It doesn't even have a name yet, as far as I can tell, but letters and numbers. And in this trial, this agent was given in combination with bevacizumab and or FOLFOX for people with metastatic colorectal cancer. And you can see there were small numbers of patients. So there was a group that received the drug who had progressed on previous therapy, and then there was another group who were receiving oxaliplatin for the first time with bevacizumab. And in these two cases, you can see in the first case, the refractory group, people had at least 3 previous treatment regimens, and then 70% of the other group had not had prior therapy. But even in this very refractory group, the group that had progressed after multiple therapies, there was still some evidence of activity in that there was a response that was seen. And in the other group, there were also responses. This will take further sorting out because we would expect people receiving a drug combination like FOLFOX for the first time to actually have a response rate. Nonetheless, these were very interesting data points that will need further work. Let's go on to the next slide. There was also another trial that presented. This trial recently and is currently recruiting patients. And this was looking at yet another anti-PDL drug combined with radiation to see if this combination will actually decrease the size of liver metastases. And you'll see here that there is a website if you are interested in investigating this particular trial. The table here is just a listing of some of the companies and the drugs. Most of these are monoclonal antibodies, drugs like bevacizumab, cetuximab, panitumumab, those are all monoclonal antibodies. You can see that some of these actually have names that are almost impossible to pronounce. There is actually a set of rules how these drugs are actually named, so they're not just made up. But some of these drugs still do not have actual names and are quite experimental. But you can see here that some of these have even entered phase 3 testing, others in phase 2 and phase 1 testing. So it's very exciting that these agents are being developed, and we'll have to see what emerges over time. Next slide. What does this mean? Well, these immunologic drugs look very interesting, but unfortunately we're going to need a lot more information to know how to use them and who will benefit. So some of you may actually be candidates to receive some of these agents, and you would need to speak with your physician to see if there are clinical trials available for you. But it is a very exciting area, and we feel that we are making at least some progress. Next slide. So you've, I'm sure, heard a great deal about biomarkers. This is what's referred to as personalized medicine, where we identify what's known as a marker, whether it's a protein or a mutation or other genetic marker on a tumor, or it may even be something in the bloodstream we can measure that would help predict who would respond to treatment. And the ideal situation is in drug development that we identify biomarkers that are tumor specific and develop drugs that will affect that particular marker, and what we hope would result in a much better outcome for our patients. So this was a study looking at what's known as an anti-EGFR drug for patients who had previously received cetuximab, for example, in colorectal cancer. And cetuximab, by the way, is also an anti-EGFR agent. And just like we talked about PD-L1 with receptors and so forth on cell surfaces, EGFR is another receptor on a cell surface, and therefore a potential target for therapy. At the current time, our most important marker is looking at RAS mutations, and what we've learned is that patients who have RAS mutations will not benefit from cetuximab or panitumumab. So anyone with a metastatic colorectal cancer should be considered for RAS mutation testing if they are candidates to receive cetuximab or panitumumab as part of their treatment program. So there at this GI symposium, there was a very early phase 1 trial with a drug known as MM151 that targets the EGFR receptor for patients who do not have either a KRAS or NRAS mutation or a BRAF mutation. And this included 29 patients with colorectal cancer and those with non-small cell lung cancer and head and neck squamous cell cancer, many of whom had prior cetuximab. The side effects of this drug were exactly what we would predict for this class of drugs, which includes rash, diarrhea, and fatigue. The initial data from this study suggests that the drug may work best in patients who do not have mutations, for example, in KRAS, NRAS, or BRAF, but have EGFR receptor positive colorectal cancer. So there's more research in colorectal cancer now that's ongoing. So these are very early data. We're going to have to see much more to see how this unfolds, but at least this is encouraging that there's yet another new drug that may have a role in the future. Next slide. And then there's a lot more going on. There's another drug, TAS-102. It's actually a chemotherapy drug. And this drug is before the FDA. We're hopeful it will be approved because this is a drug that has shown benefit for patients who have had previous multiple lines of chemotherapy for colorectal cancer. So it will expand the number of treatments available for people. And certainly there is tremendous work ongoing with biomarkers, and as I mentioned, a great deal of work now in immunotherapy. So this concludes kind of a rapid fire presentation of some of the areas of interest in colorectal cancer, and I trust we will have some time later for questions. So thanks for your attention.
Wonderful. So thank you, Dr. Benson, so much for all of your time with the presentation today. We're going to change gears just a little bit now to talk a little bit about fight colorectal cancer and specifically initiatives that we have around research and advocates and helping make some of the big linkages in terms of advocacy in the research realm. And so I wanted to say that interfacing with folks like Dr. Benson it's super helpful for our team and staff at Fight Colorectal Cancer, but it's also very important for all of you as advocates to hear the timely information for those who really seek and want to really be involved actively in advocacy and understanding of the research, as well as people who are health professionals and support and caregivers of people who are directly impacted by colorectal cancer. So one of the things that we've actually focused on, and I think Fight Colorectal Cancer is a leading organization in the field, particularly in the colorectal cancer space, is really talking about how do we make a formal linkage with research advocates in thinking about how do we really build a pipeline and people who can help be involved in advocating towards research initiatives. And we'll talk a little bit about what that means to start. But I do want to just say, we do have some upcoming events, trainings, and opportunities for folks. So what we hope to provide is a bit of information about the programs that are available, as well as opportunities for real connection to do the work in your communities at the state level, regional, local level, but also even at the national level, if that's something that you aspire to be directly involved in terms of advocacy and the research promotion and aim. So I also am excited, want to just say that I think that Kevin, myself, and other FightCRC team members who've joined the team are particularly grateful for leaders and people who have been really magens in the field in terms of research advocacy, like Nancy Roach, and a lot of people who've been involved for the last 20 and 30 years in thinking about how do research really play an active, advocates really play an active role in helping inform and shape the research agenda, and then also help really advocate for where resources are spent and how they are utilized. So I want to just start by saying, I think there's many people who advocate and who've been doing this formally and informally for years, that maybe many of us don't see them in the front line, but the work that they do and to help move the agenda forward is really amazing. So when we were thinking about the RATS program, it's actually known as a Research Advocacy Training and Support Program, which was initiated by by our founder, Nancy Roach, who's also been a leading force on our board of directors as well. But what the research aim around RATS is to really think about bringing a patient perspective and viewpoint to advocate a collective communication around the patient perspective to help inform research. And particularly what we aim and strive to do is with the RATS program is make very specific connections with academic institutions such as Northwestern, like Dr. Benson presenting today, making sort of that connection with him and his team around what are their specific initiatives, what are they working on, helping us address and understand, like today through our webinar, what are the timely topics that we should be addressing and understanding, but also then thinking about what those research institutions, academic institutions that are more college or collegial or at the academic level, also then broadening that scope to working with industry partners, pharmaceutical, as well as device companies, and then governmental agencies like NCI, NIH, and CDC to give our understanding of really what does it take to shape and inform the research. And so there's definitely a lot of different perspective that each one of those individual organization and institution hold about the development of drugs, about research around particular topics that they address, and really throughout the continuum of development, research, as well as distribution, what role and really who comes in to be a specific player to help really move forward the research agenda. So it's really one of our really big perspectives, and one of the things that we'd like to do is make sure that our advocates and folks who are working to make this link, really understand how these types of partners really do fit within the whole construct of developing research and informing drug development, as well as different types of medical care that really help patients within their communities and within their region. And our real aim and goal is to really think about how do research advocates effectively participate in this process. As patients, as caregivers, as health care providers, people actually do have a lot of their own perspective about lived experience, about what does it really mean to be a survivor, what does it mean to be impacted by these devices and drugs, and how do you also then think about that perspective that a lot of times many people don't have, that can really help shape and think about the research process. Currently, our RATS program really helps with these direct connections, and what we've really aimed to do is really create a quasi-curriculum that helps people understand what does it mean to help advocate on behalf of research, what type of personality, person, as well as time commitment is that really looking at. If there's a natural propensity or a natural ability to really understand working effectively in teams, working effectively to understand and be integrated in discussions around some of the medical care. Those things are really helpful and really crucial to being a RAT. But part of that is also just making sure to really think about being a collective voice on behalf of advocates throughout the country, throughout the world, to really just make sure that even if people who are directly involved in the science or the research really understand what is that patient perspective. It's really helpful. It's really amazing that a lot of the folks really truly do understand the science, understand the implications. But what's most important, of course, is people can share their perspective and also meld that into something that actually is a larger voice on behalf of all colorectal cancer patients. The application process is really quite easy. It's open to cancer survivors, caregivers, and champions, as well as healthcare professionals who might have, a shared or specific experience working with colorectal cancer, who can share a patient perspective. And I think that that's something that's very, very critical, is that, again, what we're really focusing on is thinking to make sure that people really can share the collective patient voice. Part of what we're really trying to strive in terms of continuing to make sure that this program is something that's available throughout the country, something that provides good support at the start as well as continuity throughout the entire process of being a RAT, is making sure to provide in-person meetings to have that really, really strong touch with folks to understand training around what does it mean to truly advocate, what does being a RAT mean, how can people really connect within their communities, and what are those resources that Fight Colorectal Cancer really can provide to make sure that this is a really good base knowledge acquirement types opportunity, a good linkage. But one of the things that we also want to do is continue to provide the support of people maintaining as a RAT with online trainings, webinars, as well as in-person meetings, so that we can continue as people move forward as on their opportunity and as their career as a RAT, that they actually continue to actually we provided additional information to help support them with additional training as well as different resources to help them be the most effective patient advocate voice within the ways that they're basically connected to the groups to help advocate. And again, a lot of times what typically happens is within IRB review boards, which are typically usually even needed even at the local hospital level or where any research is done, a patient perspective is needed. That's a direct means by which a RAT could be connected and help really share the patient perspective. There's also opportunities within the pharmaceutical as well as the governmental agency and academic institutions where folks really need people to understand, either for patient care within their institution or for specific review boards, need the patient perspective. And that could even be all the way to the top of the NCI, needing a patient perspective to help shape and inform where the research aims even are actually happening at the federal and at the national level. So the opportunities really do exist to help make that linkage. What Fight Colorectal Cancer is very excited to do is also then provide that support to make people very, 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 very astute and exceptionally activated in their communities to share the collective patient perspective as a research advocate. Next slide. So after graduating from rats, as I mentioned, a couple of the different groups that I specifically called out, but there are others, are also particularly with the FDA, the NCI, some of the specialized programs of research excellence known as SCORES, as I mentioned, the IRBs, as well as data safety and monitoring boards. The ongoing connection is something that's really important, but one of the things that I think is very important to note is that even within the national, all the way down to even at the local and community level, there's definitely an opportunity for rats to be engaged. Part of the work that we're asking folks for is even if the direct linkage in one of these review boards or even sitting in some of these panels isn't always necessarily also the end-all be-all of where you hope to go and grow as a research advocate. Even oftentimes reviewing information that's released about specific topics, information that are one-pagers or patient education or informational sheets, even for any of these groups as well as Fight Colorectal Cancer, it's oftentimes very, very helpful, constructive to make sure that we ensure that we have the patient perspective and the patient review and voice before vetting this information out to a larger distribution. And the point of this slide, as well as my point to mention, is that again, that there really are truly linkages for research advocates to play an extensive role in helping shape the voice, the vision of where research is going, as well as what information is shared. Next slide. So one of the things that we actually get asked about through rats, and I made a comment earlier, is that it really does take a specific type of person as well as someone who has a specific interest in understanding excellence in research, advocacy, education, and collaboration. Well, one of the things that we also want to think about, and I think to the slide in the intro, is that there's a lot of different places for people to really connect in their advocate mission, what it means to be an advocate. There's, of course, at the very grassroots level, there's advocacy through the legislative, governmental processes that don't really necessarily always shape the research agenda, but might be specifically for different initiatives. There's ways to become engaged in Fight Colorectal Cancer initiatives that don't necessarily mean being a direct advocate or enrolling as an advocate either in the RATS program or in the grassroots advocacy. I mean, sometimes some of that work might just really be sharing information, definitely passing and forwarding information like our Guide in the Fight and a number of the resources that we have available. But part of the thing that we're really thinking and focusing on is for the folks who really want to be involved in the RATS program is that we really want to think about what are the values that are a core component to really help make sure that RATS is the right opportunity and the right fit. So one of the things that some of the components that are tenet to this are really thinking about the value of the achievement of advocates at all levels and promotion of their accomplishments nationally and locally. Again, we wanted to make sure to infuse that even people sharing information at the local level can make a huge impact in the lives of colorectal cancer, sharing the patient's perspective and voice. Even at the national level, those are amazing accomplishments to be placed on those panels, but even nationally and locally, sometimes the impact can be just as great. We value the development of an inclusive learning community. We really want to ensure that all folks who are interested throughout the country, throughout specific populations, throughout the different types of settings are truly included in this learning community. And that means attendees and people who would like to advocate on behalf of Fight Colorectal Cancer, but it also means that people who partner with us who are looking for the opportunity to link with advocates, that it really is inclusive, which is why we've looked at the breadth of folks and partners who are really very much involved in the research idea, research development and themes, even thinking about the distribution as well as ultimately the end users, the patients, and what does that mean to really help inform that entire process. We value and support creative, critical, and reflective thinking and practices, and then we value ethical conduct by our advocates. And one of the things that we want to just remind people, of course, is that we really want to ensure that we also think about the research advocates who really can share not just their own or their personal experience, but really have the aptitude to understand what are the pressing and most timely issues that are relevant to colorectal cancer survivors. And again, that collective voice is very important. So in terms of learning more and thinking about where we're going, again, we are definitely growing a very successful program that's been embedded within the Fight Colorectal Cancer framework for a number of years. We're very excited about potentially working with a network of NCI-designated cancer centers to think about how to inform regional, state, and national perspective, really growing this throughout the country. Meaning that we really are accepting applications. We really want folks to really think about if this might be a really good opportunity and think about your own talents and passion. Visit as a first step, visit our website. We're opening applications in June, and some of our first events will be coming up even in March to actually do a small expose of what is RATS, what does it mean to really understand the science, and examine some of the issues that Dr. Benson mentioned today, but even how does that applied science work within within RATS and helping shape the research agenda. So all that to say, we're definitely excited. Again, this is a real connection to research. It puts advocates right in front and center to share their voice, but also to really continue to really be integrated in the research and the development of where research is going within our states, countries, and regions. So next slide. And just a quick reminder that our strong arm mission is that remember that we're 1 million strong. There's 1 million colorectal cancer survivors throughout the country. So the strong arm selfie and snapshot is something that we're working in partnership with Bayer. They will donate $1 for every photo passed up to 25,000. So just a reminder to do the strong arm selfie and post it on Twitter and Instagram using the hashtag above to make that connection. So it's pretty awesome that we definitely have a corporate sponsor that's helping with the movement and the message, but put real resources behind that work. Next slide. And actually, this will actually end up to us to the end of the question and answer session, or actually to the beginning of the question and answer session as we close out our today's presentation. So Kevin, I will pass off to you for our Q&A.
Perfect. Thank you so much, Andy. We really appreciate both you and Dr. Benson speaking on research and on what is happening with GI ASCO. So if everyone can hear me, Dr. Benson and Andy, are you both on?
Yes, I am.
Perfect. So we have had some really great questions come in. I'm going to start out with the questions that we received prior to the presentation to see if you could further elaborate on a few topics. So for Dr. Benson, what would you say the advances that have been made with immune system fighting colorectal cancer, anything about vaccines for CRC, any immunotherapies for stage 4?
So it was pretty much what I mentioned in terms of PDL and PDL1. We still have a long way to go in colorectal cancer compared to some other diseases such as malignant melanoma. And this is going to take further understanding of the immune system, how we can target such in colorectal cancer. There have been vaccine studies in colon cancer, but we have nothing that I would consider even close to being ready for prime time. It's all investigational. We even have challenges. You know, I talked about measuring various receptors on tumors and to see how we can develop drugs and with various receptors or other markers. And although we can investigate PDL1 and PDL actually on tumor cells, there's still not a clear association. Just because you have this expressed, it doesn't necessarily mean that you're going to benefit from an intervention, an immunologic intervention. So we still have a lot more to understand. And there are trials, and we're very hopeful there will be more trials in this particular arena.
Thank you. So related to vitamin D, what are the current recommendations for stage 2 as far as vitamin D supplements and aspirin? Could you speak to that?
There are no definitive recommendations at this time. Both aspirin and vitamin D appear to be linked to better outcome with colorectal cancer. They're also of interest as prevention strategies. Work is ongoing, but it is not yet definitive where it's in recommendations to say all patients should be on these particular agents. Having said that, there are a number of physicians who are recommending that people take vitamin D and aspirin. And aspirin, of course, is used for other purposes, for cardiovascular disease. So many patients are taking aspirin for other reasons also. I certainly talk to my patients about these type of approaches, but they're not definitive recommendations currently.
Okay. And switching gears a little bit, do you know, or where would you find out information if the ramucirumab would work with a KRAS mutation?
So that's a very interesting question, and there is a national NCI cooperative group that is looking at that combination.
Okay.
And so it's a research question, but there's actually research ongoing with the combination.
And when you were talking about that phase 3 trial and you went over the side effects and then being a little bit higher for high blood pressure and things like that, are those side effects significant enough to deter someone from doing that treatment and choosing another course of treatment?
Well, as I mentioned, the risk of high blood pressure is very well understood with this class of drugs, including bevacizumab. And so most patients, if they experience hypertension, they can be readily managed with antihypertensive drugs. So that we monitor blood pressure, and for people who have hypertension and are on medication, we would want to make sure that their blood pressure is well controlled before beginning therapy with an anti-VEGF agent. And if patients who are on medication experience further elevation of their blood pressure, then that has to be managed and their blood pressure medications must be adjusted. But it doesn't mean that people cannot receive this class of drug.
Okay. As far as immunotherapy goes, there's a lot of interest in the topic. Would you say that this is the direction that colorectal cancer treatment is going, or just one of the avenues?
It's just one of the areas of interest. We are looking for other targets for drug development, and that's an ongoing effort. As we begin to do what's called genomic sequencing on tumors, as we identify various genomic targets, we hope this will open the door to enhanced drug development. But immunotherapy is just one component of the research that's going on, an exciting and important component, but certainly not the only one.
Okay. Now there is a couple of specific questions that have come in. I just want to remind everyone we're not able to address very specific medical questions, but in general there was a question that came up about a Pfizer drug that I believe was presented at ASCO last year, and I think it's a P13 kinase drug, and the person was just asking if we have any additional information on the trial. Where would be a good place that you would recommend someone to look for updates on trials?
Well, you can start by going to websites such as clinicaltrials.gov to look for available clinical trials, and these trials should be listed on the websites. And then the best opportunity, and there should be identification of investigators who are conducting these trials, and you would be able to call the center nearest you that might have the clinical trial available.
And if you were looking for updates in the data, is that something that we could look forward to at a later date?
So for most ongoing trials, there wouldn't be, in most cases, available information because the trials are in progress, and it would be premature to present data. But for example, the various GI meetings, ASCO meetings, to look for specific topics that have been presented to see if there has been any new data presented on a given topic.
Okay.
There are also, for actual publications, there are sites such as PubMed that survey the medical literature. But for an ongoing trial, it would be unusual to be able to have much information while the trial is ongoing.
Thank you. So just as a general conclusion of the research, I have a couple more questions for Andy. But what would you say is sort of the, are there any other trials, topics, anything else that you think we should be keeping an eye on for this year?
Well, I think the best source of information is to survey the available clinical trials, because those represent the research agenda for the country. They present what's available in terms of new therapies from a research perspective. Any drug that becomes commercial, of course, that would be information that would become readily available. So, for example, if TAS-102 becomes commercially available, there will be a fair amount of information where people can investigate that, including publications. But in terms of what's really happening, I think it's why we emphasize our clinical research programs.
Definitely. Well, thank you so much. I have a couple of questions for Andy. So just if you could elaborate, Andy, on why receiving training in research advocacy is important, and why do you think these institutions are needing that patient perspective?
Sure, Kerry. That's a really great point. I think that the background and the training, I think there's a couple of different things. I think with the curriculums that we're building for the RATS program, specifically, I think that people might be really interested in certain areas to share their expertise, to share their patient perspective. So part of what we want to do is make sure that people are really connected with what is the timeliest information about the state of the science in that area. An example might be screening early prevention, people who are really interested in metastases or late stage disease. There's some focus and specific topics that we can actually provide some more information, help with linkages to specific experts to help provide this background and give people the state of the science and understanding of what might be happening in those specific areas. Those are some things that we really want to do and why it could be very helpful. Secondary to that is that in terms of understanding the research process, that it's somewhat, there is a process, and understanding the opportunity, or really what role institutions play, what really has to happen in the area of looking at evidence-based or helping really look at outcomes from research trials to understand what's considered effective, what's considering helping improve overall survival rates. What does that mean? Those are the sort of contextual pieces that we want to understand and help people understand. What are some of the indicators that are utilized within research and in science, but more even what is that process that people can really be involved in to understand really how they can help inform, and that with academic institutions and pharmaceutical companies, even within CDC and NCI, there's specific processes that actually do occur within research, and that I don't think that are oftentimes widely understood or necessarily very on the forefront without having that perspective. And so it's really important to think about how does that all fit together, as well as how do we manage from a personal perspective, how do we really become the most effective advocate in terms of sharing the perspective, sharing the voice, thinking about how to be a passionate person without becoming sometimes so emotionally connected that it can also sometimes hurt us or hurt the process. And so I think that 3 of those areas are something that RATS can really speak to, is really thinking about effective communication, how to be that research advocate who makes the proper linkages and who can really be effective, understanding specifically what area you can play a role in that linkage and the science behind that. And then third again is probably just understanding what are the processes that really make that connection, in terms of make the research wheel work of sorts. So those are 3 very specific means in which RATS can help providing that sort of training, and something that the Fight Colorectal Cancer team is very much dedicated to create that kind of curriculum to really help speak to at least those 3 areas. And then what was your second question, Kevin?
It was just talking about, why institutions need that patient perspective.
Sure. A number of institutions sometimes are actually required to have a patient, what they're actually referring to as POIs, or patient opinion leader, or POLs, POLs. That's a buzzword that we hear a lot, and that could be, specifically someone who's from FightCRC who helps share that perspective, but it's oftentimes people who are research advocates or advocates who have that lived experience as a caretaker, as someone who is specifically a colorectal cancer patient. And so that's sometimes very much required within certain types of groups, that we make sure that by law and by their bylaws that they have to have that perspective to make sure that it's a really well-rounded research aim and scope, and that we're really hearing the voice of the collective patient. Secondary to that, though, I think that there are some specific groups like Commission on Cancer, some of the NCI designated cancer centers, and also for their accreditation require patient perspective and people to be very much infused in the work that they're doing within their institution, as well as with their research committees and panels, to maintain that accreditation, there has to be a community/advocacy connection that's an authentic connection. And I think part of the point that I mentioned before is that linkage with NCI cancer centers is that that's at least a network that potentially FightCRC is looking to bridge with, that is a community and a group that have a shared vision and aim that do include research advocates. And part of, I think, what we're really exploring is, because there is this sort of network established, is how does the research advocacy aim that they have to have for accreditation, that they need to have just for doing responsible research, how does that help them within their region and within their own communities? And then it's also shared and how do we, as Fight Colorectal Cancer, help them with that aim and that mission, and so that it's really a joint effort to create a really well-rounded perspective, at least starting with colorectal cancer as sort of one of the aims, but really having a really fantastic, robust team of advocates that are throughout the country that are linked with the NCI designated cancer centers, which is something we're really exploring. Having that said, some of the community cancer centers that are COC accredited, as well as some of the other accreditations, those are other opportunities as well. That it helps keep status, it helps really see it's a win-win because it's a requirement, keep status, but it's also something that we want to ensure that beyond just sort of marking the box that this is something that's happening there, that it really means a true authentic connection to advocacy, and specifically people who have the background and training to do really good work within their, again, at the local level, regional level, state level, and even at the federal level.
Wonderful. Well, that will wrap up our question and answer session. I want to thank Andy Dwyer and Dr. Al Benson so much for presenting today on the current state of research. And so it's, topics we're all interested in following for this upcoming year. If you have any questions or any follow-up, please get in touch with us, email, Facebook, through our website. So thank you again. We really appreciate it.
Thank you.
Thank you.
Hey, Michael.
There we go. Can you hear me now?
Yes, I can hear you. Sorry, you're muted. I just saw that. I was like, hello.
That went well.
Yeah.
You sounded really, really clear. I thought it was a little technical, but
I think he presented everything as, I think it was presented really well because it's really complex. So I think it was good.
Yeah.
I think Andy wished our turnout was a little bit better. Andy Dwyer from Parks and Recreation. Lee and I have said that before. I've never told her that, so I need to.
That was the first time anybody ever called me out of that.
I need to tell her that because we've talked about that before.
That's pretty funny. I never made it to the connection until somebody tweeted me a picture. This Andy Dwyer? It's like, no. Shoe shine guy? I don't think so. But anyways, but no, it went well. I mean, we tweeted up a storm here and there, and yeah, I mean, it was. What was the final count for registrations? Because I thought we were around 70 to 80.
It was. I'll have to look back. I feel like 87 or something like that. 89 maybe.
So 30 is typically a third to a half is what we see who sign up, and I think the only thing, like I said, I was concerned with was that the larger number of people going to the registration pages dropped, but the percentage of those who are signing up is higher.
Mm-hmm.
So I'm not sure what to make of that. I guess we'll see the stats of who comes back and views the session and the presentation. So
for sure. So are you in what?
Are you still recording? I think someone.